Hi, Tennille.
Hi, can you hear me?
Hi, yes, I can hear you. How are you? It's
I'm good,
Bridget.
thanks. And you?
I'm well, thank you.
Sorry, I just want to.
You want to see if you can share your slides?
Yeah, I'm gonna do that now.
Okay, perfect.
I just want to sign into my actual Zoom. It might make it a bit easier.
Okay. This should be, did you use the link from the email?
Yes, I did.
I used the one from your account, the one that you registered with, so it should be the same one.
Oh, okay. You really were on time, eh?
Just want to make sure that everything goes smoothly.
Always
So are
better.
you, though.
Why is my password not working now? Okay. Mm,
Great, we're seeing something.
It's just, I just want to make sure I'm sharing the right one. Okay, it's the right one. Yeah.
Okay, great. Are you comfortable, Tennille?
Yes, I am. Thanks.
Okay, fantastic. We'll just wait for the others to join then.
No problem. I'm gonna mute so long because my daughter is screaming in the back. So I just want to get her away from me a little bit.
Perfect.
So.
Hi, Farah.
Hi, Bridget. How are you?
I'm well, thanks. How are you doing?
Good, thanks.
It's good to hear your voice. I just wanted to check, are you comfortable sharing your slides, or do you want to give it a bash before we start?
Sure, let me see if I can share screen.
What will probably happen is that it will kick Tennille's presentation off.
It's a power play over you, Tennille. Just want to make sure it's presenting. Looks good.
Yeah, that looks perfect from my side as well. Great. I think we're just waiting for Charlene. Hi, Charlene.
Hello.
How are
Hi.
you?
Fine, thanks. How are you?
I'm well, thank you.
This is
Um,
Bridget.
yes, sorry, yes, it's
Oh, yeah,
Bridget.
Bridget. Okay. Bridget, I'm going to ask you a huge favor. So,
Mm.
as from last week, if you could share the um,
The
housekeeping.
introduction.
Yeah,
Sure.
because I thought these complications are switching between hosts, for people to share. So, I think you just do that, and I don't want to mess things up. I'm very bad with this. Because I use my iPad and not my laptop. I should sort my new laptop out this week, because my old
No,
laptop,
it's
the video does not work.
oh, shame.
Yeah,
No,
so I have
it's
to
not a
use my
problem at all.
iPad. So I'm not good with these Apple things. I'm an Android person.
Yes, I completely understand. No problem. I'm happy to share the slides.
Okay. So,
Charlene, I think maybe what we should do though as well is perhaps in your introduction, if you could introduce both Tennille and Farah in the beginning, and then we can
sure.
just move straight from Tennille's
Yeah,
presentation to Farah's.
I
And
think
we can
that will be
actually
fine.
Okay, perfect.
Is there any special announcements? Anything extra?
No, not that I'm
Nothing
aware
new.
of. So
Okay.
yeah,
Okay.
I think just what's
Thanks.
on the slides then. And just to let you know that I've made you co-host as well, just in case
Sure.
something goes wrong. You
Just
never know.
okay. Okay.
Okay, perfect.
Thanks so much.
I'm gonna share the
So,
introductory slides so long.
so as per usual, we wait for so you said 50 people to
Oh yeah, they
join.
say about 30 to 40.
30 to
Or
okay. 30
yeah,
to 40. Okay. All
and
right.
then yeah, I suppose
Okay.
otherwise 4 o'clock.
Okay. I think and Farah says that her Zoom is updating, so she'll be on, but fortunately Tennille's going on first. So it shouldn't be a
I am
problem.
here. I managed to
Oh,
update it.
you're here. Okay. All right, great.
Okay, perfect. Okay, Charlene, I've given you remote control of the slides, so you should be able to move them from your side. Do you want to just give that a try and see if it works?
Okay, so what do I do to see if I can?
You should be able to move through them. I don't know if you either use the arrows in the bottom corner or perhaps arrows on a keypad.
Okay, let me see what this does. See, as I said, I'm not good with these things.
Okay, would you like me to just move the slides as you speak then?
You see, when you're on an iPad, where is all those buttons? Because sorry,
I'm not
things. Let me just check if I turn my iPad the other way, whether anything happens. Okay.
Potentially in the bottom left-hand corner, you might see some little buttons at the bottom of the screen. Otherwise, I'm happy to move through the slides for you.
Yeah, I think that will be better, please, Bridget.
No
Thank you.
problem. No problem.
Sorry, I'm like an old lady. I don't. My kids laugh at me. And I can't.
No, don't worry. I had to learn quite a lot of skills before I could do this.
Okay.
You're not alone.
No, but I must figure this out. I think I'm gonna get my daughter to teach it to me today.
Oh, shame, man. No worries. Lean, I think if you're ready, we can probably go ahead and start.
Okay.
Great.
Good afternoon, everybody, and welcome to this afternoon session, which we are presenting from our unit here at Albert Lutuli, UKZN. So at the moment we have about 44 participants. So whilst awaiting the rest of our audience to join, I think I'll start with the housekeeping rules before I move on to introduce my colleagues. So for those of you who don't know, we have all our recordings which can be found under resources on the Blood SA website. It's www.bloodsa.org.za. Please, during the course of the session, if you have any questions or comments, please add them to the chat box, and we will answer them depending on the nature of the question directly after each sessions, or maybe we'll leave them till the end. If you are not part of the mailing list, kindly email Melanie Davids to add you on to the mailing list for future meetings. Remember that your CPD points are automatically submitted to the HPCSA, so ensure that when you complete the registration, obviously fill in your MP number, and Melanie Davids will actually assist with sorting out your uploading of the CPD points. If you have any queries with regards to your CPD points, please contact Melanie. At the end of each session, there is a feedback form. It's a short survey, and we'd appreciate you actually filling that in so that we could use that to actually improve our future talks, and obviously to give feedback to the speakers, got both good and I hope not bad, but yeah, constructive criticism. And yeah, so I'd like to introduce the blood assay management team. And so it's Prof. Estelle Verberg, who is the deep dive leader, and Gerdien Gritzinger, who's a national training coordinator, and CPD administrator is Melanie Davids. And we'd like to thank them for all the hard work, as this does take a lot of coordination. And so we appreciate all that you do, ladies. So today we will be talking about inherited platelet disorders, and we're doing this in two parts. The first one is we're presenting a few case studies of patients that have been managed in our unit, and that will be followed by some discussion on some of aspects of some of the platelet disorders that we commonly encounter. So without further ado, I will introduce our two speakers. The first one is Dr. Tennille Abrams. So she is a medical officer that's been working in our unit since 2020, and she's the spark in our department. She's really a wonderful person to work with, and she has developed a keen interest in managing patients with various hematological disorders, and she aspires to pursue a career in clinical hematology. And yeah, so we're happy to have Tennille today discuss some of the cases we've managed. And then I'm sure you all know Dr. Farah Rahman. She is a consultant in our unit, and she completed her undergraduate training at the University of Witwatersrand in 2009. Subsequently went on to complete her internal medicine at Chris Hani Baragwanath, and she qualified as a physician in 2017. And during that time, she did her MMed on Burkitt lymphoma at Chris Hani Baragwanath. And this she passed with distinction, by the way. Then Farah subsequently joined as a clinical hematology fellow at Barra and worked under Prof. Patel and Dr. Benita Phillip and Dr. Atul Laka. And we are fortunate that she actually joined our team in 2020. And she is really passionate about her job and the patients. And particularly, she has developed a lot in stem cell transplantation and really contributes a whole lot to our transplantation program. And we're extremely grateful to have Farah in our team. And we enjoyed learning from her. She loves teaching. So you will really enjoy her talk today. So without further ado, I will hand you over to Tennille. And so thank you guys, Tennille.
Good afternoon, everyone. Thank you so much for that introduction, Dr. Parasnath. It's always a pleasure working under your wonderful supervision. So I'll be discussing two cases in our clinic that we have been observing over the years. The first case, it's a 40-year-old female that was referred to us from endocrinology. She was known with Graves' disease with the compressive goiter and was due for an elective thyroidectomy. Upon pre-op assessments, she was noted to have an isolated thrombocytopenia with an iron deficiency anemia. Her admission HB at white cell count at the time was 6.9, her HB was 11, and a platelets of 109. On further inquiry, it was noted that she had a history of chronic epistaxis, but no other history of significant bleeding. She denied any other symptoms of bone marrow failure or any bone pain. She didn't have any chronic or previous use of over-the-counter medication and no chronic NSAID use or recent NSAID use. She did, however, report that during her cesarean section in 2011, she had low platelets, but it was not investigated at the time. She had no significant family history of any bleeding disorders or hematological disorders and no other personal history. Clinically, she was well, with no evidence of active bleeding. She was mildly pale, but no lymphadenopathy or jaundice. She had no hepatosplenomegaly, and she was GCS 15/15. A repeat FBC showed a white cell count of 6.79 with an HB of 10.9 and platelets of 115. A smear was done on that sample and confirmed a decrease in platelet numbers, but her platelets were large in size. At the time, she had a normal renal function and a normal liver function. And as part of our screening for bleeding patients, she had a PT of 9.7, INR of 0.89, APTT of 27.1 with a negative antiphospholipid screen. And her thyroid function was in keeping with the diagnosis of Graves' disease. Her von Willebrand's disease screen showed a normal antigen level of 92%, with the resuscitant coactivity level of 105%, which is also normal. Flow cytometry was sent on peripheral blood at the time, and it did show adequate expression of CD42B and CD41, as well as CD61. And it was said that the diagnosis of Glanzmann's and Bernard-Solier was unlikely. However, we do know that in these cases, sometimes you can have the expression, although additionally they noted that a CD41A is usually reduced, but that marker was not offered. The platelet aggregometry was advised at the time, which we did do. Aggregometry revealed 31% aggregation with ADP at a concentration of 2. There was no aggregation with collagen at a concentration of 1 micrograms per milliliter, with 12.3% aggregation with arachidonic acid at a concentration of 0.5, but no aggregation at a concentration of 0.2 micrograms per mole, and 82% aggregation with high-dose ristrocitin. So these findings are obviously not in keeping with Glanzmann's or Bernard-Solier, which was in keeping with the flow cytometry, and they deemed it to be a normal aggregation curve. We then moved on to doing platelet function assay, which confirmed a prolonged collagen epinephrine closing time of 300 seconds, of more than 300 seconds, and a prolonged collagen ADP closure time of 162 seconds. And if we look at the interpretation, this was in keeping with the Glanzmann thrombasthenia, or uremia and liver disease, which she did not have, or von Willebrand's, which we saw she did not have either. So based on that assessment, we managed her as a Glanzmann thrombasthenia, and she's been observed in our clinic since 2019. Since then, she did report an odd episode of easy bruising, but no other significant bleeds or recurrent epistaxis, and we continued her on iron supplementation. Unfortunately, around 2021, during COVID, she was lost to follow-up, but represented to us in January 2023, again for a pre-op assessment for a possible hysterectomy following the diagnosis of a multifibroid uterus. Once the underlying condition was diagnosed, obstetrics decided to abandon the surgical route, and unfortunately for her, she was managed well with cyclopentone and Soladex. So if you look at a trend of her platelets, they've been fairly static. In June, towards the beginning of the year, it was around 173. Her last FBC with us showed a white cell count of 7.49 with an HB of 13.2 and platelets of 165. We repeated the platelet aggregometry, and again, it wasn't in keeping with Glanzmann thrombasthenia. In fact, the conclusion was there was no overt evidence of qualitative platelet disorders, but the function assay was still in keeping. So we're continuing her management as a Glanzmann's thrombasthenia. So moving on to our second case. This patient was a 20-year-old female that presented to us in pregnancy. She was referred to us from obstetrics at 27 weeks pregnant. She was a primigravida with a history of recurrent epistaxis. menorrhagia, and a history of easy bruising. She had no constitutional symptoms or other features of marrow failure, no recent use of NSAIDs over-the-counter medication, no history of previous transfusions. She did have a history of previous TB lymphadenitis when she was 4 years old, and she completed treatment for that. And she was known with childhood asthma, but she couldn't recall the last attack that she had had. She was a smoker, but denied any other substance use or toxin exposure. Significant family, however, did have a significant family history of bleeding, where she revealed she had 3 siblings and a mom that had a history of spontaneous or prolonged bleeding following various procedures. So this is one of the cases that we actually had to do some digging because it wasn't a patient known to us in adulthood. So her admission FBC with obstetrics showed a white cell count of 10.7, an HP of 11.2, and a platelets of 219. She had a normal renal function and normal liver function with a normal PT of 10.3 and an INR of 0.95. So upon further inquiry with the patient and her mom, it turns out that she and her sister were actually known to pediatric hematology and had defaulted follow-up since 2015. She recalls being diagnosed with the platelet problem at around 6 years old and remembers her sister having bruises quite often. And her mother then disclosed that she did have prolonged bleeding during a previous cesarean section. Her brother also had sustained an intracranial bleed following a minor head injury that resulted in a basic skull fracture as well. So this is when we really became detectives trying to find where the diagnosis or what the problem was. So we searched back into previous results. At the time, there was a bleeding time test that was done that was normal. The upper limit of normal was 9.5. Her result was 9. She had a normal INR of 1.07 with a prothrombin time of 9.8. Von Willebrand screen showed an antigen level that was normal at 116%, with the ristocetin cofactor of 92%. And aggregometry showed that she had normal aggregation to ristocetin, as well as a arachidonic acid. But epinephrine showed no platelet aggregation. However, this was noted that it could be normal as well. So the first aggregometry that we found was actually found to be inconclusive, and there was no, couldn't definitively confirm or exclude the presence of a platelet function disorder. So finally, we saw a repeat aggregometry test that was done in 2005, and this confirmed that the patients had a decreased response to epinephrine at low levels, a decreased response and a reversible response to ADP at high concentrations. A longer lag phase was also noted at all concentrations with collagen, with a normal response to ristocetin and arachidonic acid. And these findings are not classically suggestive of any specific platelet function, but they did say it was possibly a storage pool disorder, thromboxane A2 defect, or abnormal calcium flux. The PFA done in 2005 showed epinephrine level of 133 and ADP of 80. And at that point, we saw in pediatric notes that they were actually treating her as a platelet storage pool disorder. And unfortunately, patients was lost to follow-up over the years. So once we finally figured out the diagnosis, we co-managed these patients with obstetrics. And the aim was to ensure a controlled delivery. The plan was to induce her at around 38 weeks, and it was encouraged that she'd have a normal vaginal delivery. However, if warranted, obviously a cesarean section would be done, but ensuring that platelets were available and possible desmopressin if needed. Luckily for her, she had an uneventful pregnancy with no history of bleeding or fetal compromise. And just under 39 weeks, she was admitted for induction of labor. Unfortunately, medical and mechanical induction and augmentation failed, and she ended up having a cesarean section for poor progress. Fortunately, though, she had minimal blood loss, about 500 mils. And prior to a cesarean section, she had a normal thromboelastogram and a platelets of 182. She did not require any platelets or red cell infusions. And she delivered a healthy female baby with good APGARs. And obviously, this baby was referred for genetic testing, given the the prevalence, or rather the autosomal dominance underlying condition that a family had had. Of note, the platelets remained fine-ish, if you can say. After delivery, platelets 182 and then 176. Following the delivery of a baby, the patient was seen in our clinic every 4 months. She doesn't report any significant bleeding and does use tranexamic acid when needed, especially for bouts of menorrhagia. And she's been constantly advised on the avoidance of NSAIDs and cessation of smoking. Her daughter was tested at 2 years old and remained negative, and she's due to be repeated when she's 6 years old. Thank you so much.
Oh, thank you, Tennille. I just want to check. There's no questions on the chat. So I think we will move on to Farah and then perhaps have our discussion at the end. Thank you very much. So over to you, Farah.
Hi, everyone. Thank you for the introduction, Charlene, and thanks to Neil for presenting the two interesting cases. So we're going to go through an approach to the inherited platelet disorders, and I do have one disclaimer. I am by no means an expert in inherited platelet disorders, and my heart sank when this topic was chosen because this is one of those conditions that I always have to look up and read whenever we encounter it in the clinical setting. So maybe the topic should have been a confused clinician's approach to the inherited platelet disorders. I felt a little bit better about myself when I saw Prof. Lowe posting the article about demystifying inherited platelet disorders a couple of weeks ago. So I think I'm not the only one who finds this to be a very complicated topic. Not sure why my slides are not moving. Okay, there we go. So we all know that platelets play a huge role in hemostasis, and they have many other physiological and pathological processes. We make about 10 to the power 11 platelets every day. The inherited platelet disorders themselves are a group of very heterogeneous disorders consisting of about 60 rare diseases that we've identified so far. And these are caused by genetic abnormalities in over 75 genes that have been found to date. The disorders may be qualitative or quantitative in nature, and the prevalence is about 1 in 10 to the 4 to 1 in 10 to the 6 persons worldwide, depending on the clinical setting and the demographic of the audience that you are testing. Clinical manifestations can range widely from being asymptomatic to life-threatening. People may often present with mucocutaneous bleeding or have syndromic features or multi-system involvement, and some conditions may confer a tendency to development of malignancies. So the early and accurate diagnosis of these inherited disorders with close follow-up is of great importance, and it's really important to start off by taking a thorough personal and family history, looking especially for the history and pattern of bleeding with or without surgery or trauma, the intake of food or medications that can affect platelet function, as well as a family history of thrombocytopenia or other malignancies. We've all heard of bleeding assessment tools, and these can be useful in standardizing the severity of bleeding. Following a comprehensive history, a complete physical exam should be performed, including assessing for bleeding patterns and looking for syndromic features. So we're going to spend a little bit of time looking at this picture, which looks kind of confusing, but I was hoping would be sort of a summary, showing you the different bits of the platelet and the proteins and what will happen when things go wrong in different parts of the platelet. So you can get an adhesion or an activation defect if you have issues with collagen. If you have defects of procoagulant activity, you can get something known as Scott syndrome. Defects in the calcium channels will result in Storm-Walken and York syndrome. If you have issues with the GP1B95 receptor, you may result in Bernard-Soulier syndrome. If you have issues with the granules, like an alpha granule deficit, may result in gray platelet syndrome or the Quebec syndrome. If you have problems with integrin, that can result in Glanzmann's thrombasthenia. If you have issues with the delta granules, then you may manifest Hermansky-Pudlak syndrome, Shediac-Higashi syndrome, amongst others. Then if you have problems with the von Willebrand factor antigen GP1b95, you can get platelet type von Willebrand disease. Defects in your cytoskeletal proteins like the Wiskott-Aldrich syndrome protein can obviously result in platelet abnormalities, can also result from defects in enzymes of the thromboxane A2 pathway. And then issues within the substances that are secreted from your platelet granules, such as epinephrine or ADP, will result in platelet disorders. So if we look at a broad classification of inherited platelet disorders, we can break it down into platelet defects, platelet receptor defects, platelet granule defects, and we always throw in the category of other. So let's talk about the inherited defects of platelets. So there's going to be a bunch of tables here, which goes through all 60 types of identified inherited platelet disorders. And for the sake of time and the sake of generally everybody's sanity, I'm not going to go into detail about all 60 of these conditions, but I'm just going to highlight some of the ones that we probably should have at least heard of. So this first set of tables classifies the inherited platelet disorders in terms of platelet size. So the first few conditions are those which have inherited thrombocytopenias with a normal platelet size. So we may have heard of congenital amegakaryocytic thrombocytopenia, which is inherited in an autosomal recessive pattern and will manifest as a very severe neonatal thrombocytopenia where there's amegakaryocytosis and often associated with the progression to aplastic anemia in childhood. This will be a severe bleeding tendency. Other conditions you may have heard of could be things like thrombocytopenia with absent radii. Again, an autosomal recessive pattern of inheritance also presents as a neonatal thrombocytopenia, which is moderate to severe, that actually improves with age. And it's associated with skeletal abnormalities. The name tells you, bilateral absence of the radius. They may also have kidney, heart, or central nervous system abnormalities, and they have a severe bleeding tendency. If we look at more of the disorders associated with a normal size platelet, there's things such as the Storm-Walken syndrome, which is an autosomal dominant pattern of inheritance, presents as a moderate thrombocytopenia with a mild bleeding tendency. Going on to the next category of inherited thrombocytopenias with large platelets, I'm sure we've all heard of Bernard-Soulier syndrome, which is inherited in an autosomal recessive pattern, presents with a moderate to severe thrombocytopenia with giant platelets. And there will be absence of platelet aggregation with ristocetin, which is not restored with plasma. And this is because of the absence or the severe dysfunction of the main von Willebrand's factor platelet receptor. There is a reduced response to other agonists as well. And this will manifest with a severe bleeding tendency. There's also a Bernard-Soulier syndrome monoallelic form, which is different in that it has an autosomal dominant pattern of inheritance, and will present with a mild to moderate thrombocytopenia with an absent to mild bleeding tendency. We all should have heard about platelet type von Willebrand disease, which is an autosomal dominant mode of inheritance, also affects the gene GP1BA, which was the same gene affected in Bernard-Soulier syndrome. This will present as a mild to severe thrombocytopenia. The platelet count can be normal, but it will decrease under stress conditions, and clinically will manifest as absent to a mild bleeding tendency. There are some syndromic conditions, such as Dye-George syndrome or velocardiofacial syndrome, which is inherited in an autosomal dominant pattern due to deletions in 22q11. And this presents as a moderate thrombocytopenia associated with abnormalities of the cardiac system, parathyroid glands, and thymic insufficiency. There's also cognitive and developmental delays with facial dysmorphia. There may be conditions related to GATA1 abnormalities, and these are X-linked pattern of inheritance, presenting with mild to severe thrombocytopenia, can also be associated with dyserythropoiesis, and there may or may not be an anemia. And the bleeding tendency here is mild to severe. And there's even more. So I'm sure we've all heard of the gray platelet syndrome, which is an autosomal recessive pattern of inheritance, presents as a moderate to severe thrombocytopenia, and typically you see grayish platelets. It could get aggravated over time and be worse, and it will clinically present with moderate to severe bleeding tendencies. I think that all of these are not very common disorders, so I'm not going to go through them. Then we also get in the last category of inherited thrombocytopenias with small platelets. I think probably the most common of these would be Wiskott-Aldrich syndrome and X-linked thrombocytopenia, both of which are an X-linked pattern of inheritance. Wiskott-Aldrich syndrome will affect the WAS gene and presents with a severe thrombocytopenia, but is also associated with immunodeficiency, skin diseases like eczema, and a tendency to develop lymphoproliferative and autoimmune disorders. The bleeding tendency here is severe. So if I try and put it a little bit more simply, the classification of inherited platelet disorders with thrombocytopenia according to platelet size can be those with a normal platelet size, large platelets, or small platelets. The category of normal platelet size contains things like congenital amegakaryocytic thrombocytopenia or thrombocytopenia with absent radii or Sturm-Morgan syndrome. Those with large platelets include Bernard-Soulier syndrome, platelet type von Willebrand disease, Di-George syndrome, and GATA1 related thrombocytopenia. And those with small platelets include Wiskott-Aldrich syndrome, X-linked thrombocytopenia, among others. Let's go on to the next category where it's not really associated with thrombocytopenia, but you're also getting now defects of the platelet receptor. So again, another large table, and we've mentioned some of these in the first category. So when the receptor involved is the 1B95 receptor, this can result in Bernard-Soulier syndrome that we've mentioned already, as well as platelet type von Willebrand's factor. If it's the alpha 2B beta 3 receptor, that will result in Glanzmann thrombasthenia, which is a common one we should know about, with an autosomal recessive pattern of inheritance. This will present with a normal platelet count and normal platelet morphology. And when you do light transmission aggregometry, you will see absent or severely reduced aggregation with all agonists. And with the ristocetin, it would be normal, or the second wave would be reduced. There will also be absent or severely reduced clot retraction. And this will confer a severe bleeding tendency. Some other common conditions affecting the receptor include the P2Y12 receptor, and this will be the ADP receptor deficiency, which can be autosomal dominant or recessive in inheritance. Another one we should probably know about is the thromboxane A2 receptor, which, if it's defective, will result in thromboxane A2 receptor deficiency. Again, this can be autosomal dominant or autosomal recessive. So these issues with the platelet receptor, you may notice in the table that they tend to have a normal platelet count and morphology. But it's on light transmission aggregometry that you will pick up the abnormalities. Moving on to the next category, we're going on to inherited defects of platelet granules. So you may have defects of both alpha and delta granules together or in isolation. If it is together, this disease is known as idiopathic granule deficiency. The pattern of inheritance can be either autosomal recessive or autosomal dominant. So in this condition, the platelet count may be normal or slightly decreased, and there should be normal platelet morphology. But you can pick up the delta and alpha granule deficit by means of electron microscopy. So they may not have bleeding symptoms, or they can have, I like the term, very moderate hemorrhagic symptoms, but this will usually be associated in situations associated with bleeding risk, like trauma or surgery. If there are issues with the alpha granules, may result in gray platelet syndrome, which can be autosomal recessive or autosomal dominant, or the Quebec syndrome, which is autosomal dominant pattern of inheritance. These patients will generally respond to antifibrinolytic therapy to reduce the risk of bleeding, but they may lack a response to platelet transfusions. And there's various deficits of delta granules, so the Hermansky-Pudlak syndrome, which is autosomal recessive, Chiriac-Higashi syndrome, which is autosomal recessive as well. And this condition is associated with a normal platelet count and morphology, with the granule deficit picked up by electron microscopy. Light transmission aggregometry will show a reduced or absent secondary aggregation wave with weak or low dose agonists such as ADP, epinephrine, and collagen. Remember that it's the secondary wave of, that it's the granule release that is responsible for the secondary wave of aggregation that is seen with platelet aggregometry testing. In terms of other platelet defects, so there can be issues affecting enzyme activity or signaling pathways. So there may be defects in the thromboxane A2 pathways or G protein defects. You may also have defects of procoagulant activity, and this can result in conditions such as Scott syndrome or Storm-Walken syndrome. For the sake of time, I'm not really going to go into detail for these conditions. So this, I thought, was a nice little summary of all of those busy tables to help to classify the inherited platelet disorders according to what abnormality is present and what platelet components are affected. So if there's an abnormality of the platelet receptor for adhesive proteins, it could be your glycoprotein complexes, which may result in Bernard-Soulier syndrome, the platelet type von Willebrand's disease, and Glanzmann's thrombasthenia. If there's abnormalities of the platelet receptor for soluble agonists, this could involve the P2Y12 receptor or the thromboxane A2 receptor, which would give you the corresponding receptor deficiency. It could be abnormalities of the platelet granules we've mentioned above, if it's abnormalities of delta granules or alpha granules or a combination of the two. There may be defects in signal transduction, which may affect the arachidonic acid pathway or thromboxane A2. Phospholipase activation may also be affected. There could be abnormalities of the membrane phospholipids themselves, and there could be miscellaneous abnormalities of platelet function. So something that's conferring a primary secretion defect or other things, like osteogenesis imperfecta or connective tissue diseases, like Ehlers-Danlos syndrome or Marfan syndrome. So how would you investigate a suspected inherited platelet disorder? So firstly, you need to take a detailed clinical history and do a physical examination. And the laboratory workup should always begin based on what you are suspecting from history and examination. Routine tests would include a full blood count and a differential and a peripheral blood smear, a prothrombin time, an activated partial thromboplastin time, and screening tests for von Willebrand's disease, including von Willebrand factor antigen and the ristocetin cofactor activity, as well as coagulation factor 8 activity. But it's important to exclude other conditions not related to inherited platelet disorders prior to commencing the workup, such as an immune thrombocytopenia. So a full blood count with the peripheral blood smear should be the initial diagnostic test. If there's a normal platelet count, but you still suspect an inherited platelet disorder, then you evaluate platelet function. If the patient has thrombocytopenia, the platelet size can guide further evaluation. If there's a microthrombocytopenia, things that could cause this include Wiskott-Aldrich syndrome and X-linked thrombocytopenia, as we've seen in the previous tables. There's a thrombocytopenia with a normal platelet size that can be related to various causes, as both acquired and inherited. If there's a macrothrombocytopenia, we may see this in Bernard-Soulier syndrome or MYH9 related disease. The platelet size can be estimated on the full blood count using the mean platelet volume. And a mean platelet volume of more than 12.4 femtoliters is quite sensitive and specific to help to differentiate inherited platelet disorders and ITP. And you'll see where this fits in when we do a summary at the end of this talk. New analyzers can actually provide an immature platelet fraction relative to mature platelets. So immature platelets are the most recently produced platelets that are released into the peripheral blood from the bone marrow. And since the number and proportion of the immature platelets will then reflect the rate of thrombopoiesis, they represent thrombopoietic activity. So the immature platelet fraction will be higher in inherited platelet disorders than in immune thrombocytopenia and other causes of thrombocytopenia. Gray or pale platelets means that there's decreased or absent platelet granules. So that can be an important clue on morphology of gray platelet syndrome. Additionally, look at the morphology of the other cells because that can provide valuable information. So if there's Dolly-like bodies in the neutrophils, that could be a finding of MYH9 related disease. If there's abnormal red cell morphology, that could suggest a GATA1 mutation. If there's giant neutrophilic granules, that could suggest the presence of Shediac-Higashi syndrome. So these are some peripheral blood smears in some of the inherited platelet disorders. So you can see in figure A, the arrows are showing you Dolly-like inclusion bodies in a neutrophil and a large-sized platelet in a patient with MYH9-related disorder. Picture B is showing you a platelet with the absence of normal cytoplasmic color in a patient who has gray platelet syndrome. Picture C and D are transmission electron microscope images of platelets. Picture C is a normal patient, and picture D is a patient who has a marked deficiency of alpha granules. And picture E is showing you the neutrophilic granules in a patient with Shediac-Higashi syndrome. So let's move on to platelet function assays. So light transmission aggregometry measures the ability of various agonists to platelets to induce the in vitro activation and platelet-platelet activation. Light transmission aggregometry uses platelet-rich plasma, which is stirred in a cuvette at 37 degrees Celsius. The cuvette sits between a light course and a photocell, and when an agonist is added, the platelets aggregate, and thus they absorb less light, and so the transmission increases, and this can be detected by the photocell. So what will be measured on light transmission aggregometry would be the shape change, the length of the lag phase, the rate and maximal percentage aggregation at the end of the monitoring period of aggregation, and the presence of a secondary wave, which is induced by epinephrine. So in terms of interpreting light transmission aggregometry, you get impaired platelet aggregation with more than one agonist. That would suggest that there's an inherited platelet disorder. The absence of aggregation of all agonists except for ristocetin indicates Glanzmann thrombasthenia. The absence of a response to ristocetin suggests Bernard-Soulier syndrome. A markedly decreased or absent aggregation of ADP suggests a P2Y12 receptor abnormality, whereas decreased aggregation responses to collagen and the absence of secondary waves to epinephrine and ADP will point to platelet storage pool defects. Increased platelet aggregation in response to low concentrations of ristocetin is compatible with platelet type von Willebrand's disease, with the gain of function phenotype of platelet GP1BA has an increased avidity for von Willebrand's factor. A normal light transmission aggregometry result does not entirely exclude an inherited platelet disorder. So they may be normal or only slightly defective in some of the milder platelet function abnormalities, particularly if there's a dense granule deficiency. Abnormal aggregation patterns to epinephrine are commonly observed even in non-inherited platelet disorder cases. So you need further diagnostic processes if there's other abnormalities or you have a strong clinical suspicion. And the type of abnormal aggregation pattern in the light transmission aggregometry will determine which workup will be required for the next step. So these are some examples of platelet aggregometry, I guess, graphs that you may see. So the first two pictures on the top, A and B, show a normal aggregation pattern to various platelet aggregates. C shows you the results in Bernard-Soulier syndrome, where you can see the absence of aggregation to ristocetin, but normal aggregation to other agonists. D is the results of a patient with Glanzmann's thrombasthenia, where you appreciate absent aggregation with all agonists except ristocetin. E and F show you the results in platelet type von Willebrand disease, where there's normal aggregation to all agonists, and aggregation is also observed at low concentrations of ristocetin, which doesn't occur in normal specimens. And this is what I was alluding to earlier when interpreting light transmission aggregometry in various inherited platelet disorders. There may be these typical patterns of results that you can get. So we'll mention Glanzmann's thrombasthenia again, where you will see absent aggregation with all agonists except ristocetin. If somebody has something like Wiskott-Aldrich syndrome, there'll be impaired aggregation and secretion induced by several agonists. But notice the last 6 conditions, the congenital amegakaryocytic thrombocytopenia downwards, can actually have normal light transmission aggregometry results. This is just another table that was summarizing the different findings that you can get in the different conditions. So I'm not going to go through this again. So there's definitely a lot of challenges associated with light transmission aggregometry. One of them is that it requires fresh blood, and it requires relatively large volumes of blood, between 20 to 50 milliliters of blood. You can see how that could be challenging to implement, especially in small children with suspected inherited platelet disorders. It's time consuming, and it's also technically complicated. There is a whole host of pre-analytical and analytical variables which can affect the results, and you need meticulous control by expert laboratory personnel. It cannot routinely be performed in many labs because this expert laboratory personnel is not that readily available. Abnormal results should be rechecked as well by performing the test on a second sample to exclude the effect of pre-analytical variables. So you can see that it can also add to the cost of working on patients. Whole blood aggregometry is an alternative method for measuring platelet aggregation. And in whole blood aggregometry, this measures the change in electrical resistance between 2 electrodes, which are immersed into a whole blood sample, which results from the adhesion of platelets to the electrodes and subsequent platelet aggregation. So with whole blood aggregometry, it overcomes the issue of sample volume. So it can be a test that's suitable to use in young children, but it cannot provide information about changes in platelet shape or the presence of secondary waves or deaggregation. Also, the reproducibility, sensitivity, and specificity haven't yet been established, and the correlation with light transmission aggregometry is poor, as is its ability to predict clinical outcomes is debatable. So the use of platelet function analyzers, the PFA 100 or the PFA 200, for screening abnormal platelet function is not actually recommended because of a lack of reproducibility and a low sensitivity and specificity for inherited platelet disorders. Because a prolonged closure time can't discriminate between von Willebrand's disease and other inherited platelet disorders, and a normal closure time does not rule out mild platelet function disorders. The results on a PFA analyzer are also affected by low hematocrit and platelet counts, so they are not reliable in patients who are severely thrombocytopenic. So just to mention for those who may not know how a PFA works, the PFA is a system for analyzing platelet function in which whole citrated blood is aspirated at high shear rates, going through disposable cartridges which contain an aperture within which a membrane is coated with either collagen or epinephrine or collagen and ADP. And these agonists then induce platelet adhesion, activation, and aggregation, which leads to a rapid occlusion of the aperture and the cessation of blood flow as for how long it takes to occlude the aperture is measured as the closing time. The advantages of a PFA is that you require a small volume of blood, about 800 microliters. So this could be useful in young children. It's rapid, it can be automated. It's more standardized than a bleeding time, which I think a bleeding time has largely fallen away. It's more physiological because it measures the platelet function at high shear rates, whereas light transmission aggregometry is measuring function at low shear rates, which is less physiological. It's it's insensitive to clotting factor deficiencies, and it has a high negative predictive value. But just remember that the PFA is affected by the citrate concentration, the collection time, so samples need to be processed within 4 hours of collection, the hematocrit, like I've mentioned, the platelet count also affects results. The blood group and the Willebrand's factor levels can also affect results. Drug use, like non-steroidal anti-inflammatories or antiplatelet agents like clopidogrel, will affect results. And yeah, it's enough there. So in terms of platelet secretion assessment, this can be assess impairment of granule release by methods such as Lumi aggregometry, luminometry, high-performance liquid chromatography, ELISA, or flow cytometry. It should also be possible to check for ADP or ATP release and at least a marker of alpha granules. If an alpha secretion defect is identified, the next step is then to measure the granule content. So flow cytometry can assess the platelet glycoprotein expression using antibodies against glycoprotein 2b, which would be CD41, glycoprotein 3a, which is CD61, glycoprotein 1b, which is CD42b, and glycoprotein 9, which is CD42a. The glycoprotein 2b3a activation epitope can be used on activated platelets, and defects in glycoprotein expression can indicate well-defined inherited platelet disorders. The reduced expression of glycoprotein 2b3a will confirm the diagnosis of Glanzmann's. The defective expression of glycoprotein 1b9 is characteristic of Bernard-Soulier syndrome. So the table on the right is the key summary recommendations from the ISTH on using flow cytometry for the assessment of disorders of platelet number and function. So the clinical utility, we've mentioned it can assist in the diagnosis of those listed disorders. But again, remember that all of these tests can be affected by a variety of pre-analytical, analytical, and interpretive variables. So always make sure that you've excluded the medication history, that your sampling is done correctly, that you minimally shake the tube so that you don't prematurely activate coagulation and all of those things. Also, things need to be at a physiological temperature of 37 degrees Celsius for most tests. So other tests that can be used in the setting of inherited platelet disorders include transmission electron microscopy, where platelet structure related to platelet function can be assessed. Example, the number of alpha and delta granules. Can also identify structural alterations that can be diagnostic for certain conditions. Another example of an assay that can be used is a clot retraction assay, which can assess the impairment of clot retraction, which can be found in Glanzmann's thrombasthenia or Storm-Walken syndrome. So there's been a whole hive of activity regarding genetic analysis with inherited platelet disorders recently, and at least 75 genes associated with inherited disorders have been identified. The molecular analysis can be a diagnostic tool, but it also provides information on prognosis and the disease cause, such as those disorders which are associated with myelofibrosis, leukemia, lung fibrosis, all of the syndromic conditions. Sanger sequencing of specifically targeted genes would be the most widely used molecular analysis method, and it is especially useful for monogenic disorders. If there's an affected family member with a confirmed disorder, or when the specific familial genetic variant is already known. Next generation sequencing can effectively detect sequence variants and small insertions or deletions. Array comparative genomic hybridization or multiplex ligation-dependent probe amplification can be performed to confirm copy number variants. But recently, the advent of high-throughput sequencing may allow an affordable and relatively fast molecular diagnosis. So the pros of genetic testing is that it requires a very small amount of blood compared to the other tests. So the diagnosis in children is possible. Also, the functional tests require fairly fresh platelets within 4 hours. However, DNA that is used in genetic testing has the advantage of being more stable, so you don't have to get it fresh, warm, and steaming to the lab necessarily. The cons are that it needs to be interpreted within the clinical context and whether it is reported as a disease mutation in the database to avoid the risk of over-interpretation. The specificity of a clinical phenotype is the most critical information that needs to be used when interpreting genetic data and determining clinical significance. There's also ethical issues that are arising. For example, with regard to the possible identification of variants involved in germline predispositions to malignancy, and that will require transparency. And it should be considered during genetic counseling because they are associated with a much higher psychological burden than should be expected in the context of evaluating a mild or moderate inherited platelet disorder. So these pictures are pretty much the same picture, showing you which genes are involved at which stage of the life cycle of the platelet. So in early megakaryopoiesis, at the level of the hematopoietic stem cell, defects in the MPL gene or THPO can result in an inherited platelet disorder. The level of the early megakaryocyte, it would be things that affect transcription regulation like GATA1, RUNX, ETV6. Later in megakaryopoiesis and with proplatelet formation, genetic issues involving granule biogenesis and traffic may cause disorders. And then there's some things where the pathway is incompletely defined, such as those genetic disorders is that either orange or red. In terms of proplatelet formation, there can be genetic issues which cause abnormalities with cytoskeleton regulation. And these are the ones that we've heard earlier in this talk: MYH9, Wiskott-Aldrich, WAS gene, those involved in the glycoprotein signaling like GP1BA, von Willebrand's factor. And then late in the mature platelet, genetic issues can be those that affect signaling or receptor signaling and other genetic defects like of ANO6. So this is an attempt to summarize a diagnostic algorithm for inherited platelet disorders. It is not my summary, so I won't take credit for it, but I thought it was a good summary. So in a patient that you suspect an inherited platelet disorder based on history and physical examination, the first investigative step is to do a full blood count and a peripheral blood smear. This can either show you that the patient has a normal platelet count or the patient has a thrombocytopenia. If there's a normal platelet count, you should start with von Willebrand's disease studies, including an antigen and activity. If it is abnormal, then you have diagnosed platelet type von Willebrand's disease or von Willebrand's disease type 2B. If von Willebrand studies were normal, then you look at platelet aggregation. So you can do a test like light transmission aggregometry. If there's a non-specific pattern, then consider an acquired platelet function disease or systemic disease like liver or kidney disease, or even a mild inherited platelet disorder. If your aggregometry tests show a significantly abnormal pattern, then look at things like granule release defects and surface protein defects in order to diagnose either granule release issues or surface protein issues, which will require further genetic analysis. Remember that if your light transmission aggregometry shows a significant abnormal pattern, this may be suggestive of things like Bernard-Soulier syndrome, platelet type von Willebrand's disease, or Glanzmann's thrombocytopenia. If, however, your patient's full blood count showed you a thrombocytopenia, you can then look at your peripheral blood smear to assess if there are large, normal, or small platelets. There's an error in the block for large platelets. It should be a mean platelet volume of more than 12, not less than 12. This is suggestive of diseases like MYH9-related disorder, 22q deletion syndrome, in which case you will go further and do genetic analysis. If there are normal sized platelets, you'd consider things like congenital amegakaryocytic thrombocytopenia or TAR syndrome. And you should be doing a bone marrow analysis on these patients because of the association with hematological disorders that have a tendency for leukemia formation. And you can also go on to do genetic analysis for these patients. And if there are small platelets with a mean platelet volume of less than 6 femtoliters, consider Wiskott-Aldrich syndrome or X-linked thrombocytopenia, in which case, because of its tendency to be associated with immune deficiency, you should in addition assess immune function. And there is a role for genetic analysis here as well. So this is just another little summary from the ISTH on their recommended investigations for suspected inherited platelet disorders. So firstly, in order to confirm a bleeding diathesis, again, you need to take a good personal and family history of bleeding and assessment of associated syndromic findings. The bleeding assessment tool is always very helpful when you are assessing a patient's bleeding history. Your initial investigations includes a full blood count, a peripheral blood smear, exclusion of a coagulopathy and von Willebrand's disease, light transmission aggregometry, the granule release by luminometry or ELISA, and flow cytometry. Then second-line investigations would include things like extended panels for a light transmission aggregometry, an extended panel on flow cytometry, assessing platelet procoagulant activity, doing electron microscopy to look at the granules and the ultrastructure of platelets, clot retraction assays, mixing studies, and optional investigations would include genetic testing and other tests like assessing the levels of serum thromboxane. Remember that QC matters a lot when it comes to investigating inherited platelet disorders. So there's a bunch of pre-analytical and analytical variables that always need to be taken into consideration. So in terms of pre-collection, pre-analytical variables, just pre-collection, the person needs to be well rested. They shouldn't have smoked for at least 30 minutes before the test, shouldn't have had caffeine for 2 hours before the test. You need to make sure that they didn't take any medications that could affect platelet function testing, such as non-steroidal, anti-inflammatory drugs, aspirin, any antiplatelet agent. When the blood itself is being collected, it should be drawn with minimal or no venostasis, with a needle of an appropriate size, into a tube of appropriate material, into the correct buffer, being sodium citrate. It should be transported, hand carried at room temperature without vibration or shaking. It should be stored at room temperature. The way you prepare the platelet-rich plasma needs to be done according to standard specifications. And then in terms of the analytical variables that need to be taken into consideration, important is the temperature, which should be done at 37 degrees Celsius. You need to have a control so that you can interpret your results. And just the way that even the stirring of the sample is done needs to be done at a specific rate and for a specific time. So there's a lot of things that can affect your results of platelet functional analysis. And you always need to take into consideration, is this really an abnormal result? Was there some pre-analytical or analytical variable that went wrong? So you'll see that these tests are never just done once and people are happy with the result. They always need to be repeated, and you need to ensure that things were done correctly in order to interpret that result. So in terms of management of inherited platelet disorders, unfortunately, unlike the advances in diagnostics, there hasn't really been major changes in the clinical management of patients with inherited platelet disorders. The focus rather is on educational and preventative measures. So try to avoid getting hurt, have good dental hygiene, don't take any antiplatelet drugs. And I think it's important for people to be included into registries so that we can actually know the extent of what we are dealing with. Patients need regular follow-up by specialized hematology services with multidisciplinary support, especially in those patients and families that have syndromic inherited platelet disorders. There are certain complications where there are certain situations, where there is a bleeding risk. And in these situations, you can use hemostatic drugs like antifibrinolytics or desmopressin. When necessary, patients can use recombinant factor 7A or platelet transfusions. How recombinant factor 7A will work is by increasing thrombin generation. So this is licensed and it's mainly used in Glanzmann's thrombasthenia, especially in patients who are refractory to treatment with platelet concentrate. There's not much evidence for the remaining platelet syndromes, but it has been successfully used to treat or prevent bleeding in a few patients with Bernard-Cillier syndrome and in one patient with thrombocytopenia with absent radii. Remember, there is a high risk of alloimmunization, so platelet transfusion should be restricted only to severe bleeds in which antifibrinolytics and local measures have failed, or in patients with very severe thrombocytopenias who are about to undergo major surgery or during childbirth. Leukodepleted single donor or HLA identical platelet products will be preferable for patients with inherited platelet disorders. And when it's necessary to improve the thrombocytopenia, such as if there's a high bleeding risk surgery, treatment can involve the use of platelet transfusions, or in some case, a thrombopoietin receptor agonist like L-thromboplag or romiplastin. The syndromic inherited disorders will require a multidisciplinary clinical approach. For example, patients with MYH9 disease, they will require regular urinalysis because the appearance of proteinuria can support the use of therapies like ACE inhibitors or angiotensin receptor blockers for a protein-sparing effect in order to reduce the risk or delay kidney failure. They will also require routine hearing and eye examinations. Patients who have the RUNX1, ANKRD26, or ETV6 mutations will actually require a bone marrow evaluation at the time of diagnosis. If there's no significant finding identified, they will then require an annual full blood count, a blood smear, and clinical evaluation to identify early signs of malignant disorders. In this case, if there is a malignant disorder that does arise, then an allotransplant should be a consideration. But remember that there could be germline mutations, so the family stem cell donors will also need to be tested and ruled out for molecular alterations that the patient has. An allotransplant is the only curative therapy which is available for inherited platelet disorders with very severe bleeding symptoms that have a high risk of transformation to bone marrow aplasia, or in those with a hematological malignancy. An allotransplant is best performed in childhood because at this age, there is the lowest risk of complications from transplant. So what about gene therapy? So gene correction has the potential to be curative for patients with severe inherited platelet disorders. To date, it was an experimental clinical option only for some cases of Wiskott-Aldrich syndrome. And they went about doing this by treating autologous hematopoietic stem cells, which were transduced with self-inactivating lentiviral vector encoding WAS protein. So in these cases, all except one child had sustained cell engraftment, and their platelet counts and functions improved. The bleeding and immunity improved significantly, and there was no relevant vector-related toxicity. For the other inherited platelet disorders, however, gene therapy is still at the preclinical level of research. So just some closing remarks is that inherited platelet disorders should be among your differential diagnosis when the patient shows mucocutaneous bleeding. In patients who have a family history suggestive of a hereditary cause, or patients with significant bleeding histories, a comprehensive evaluation for the presence of an inherited platelet disorder should begin. After a thorough history and physical examination, basic lab tests include the full blood count and routine coagulation tests, and they are widely available, and they should be the initial diagnostic steps. Thereafter, a stepwise approach using platelet function tests and flow cytometry is essential to diagnose these disorders. Molecular analysis has become more popular these days, and it can help in accurate diagnosis. It can also assist in optimizing treatment when appropriate genetic counseling is provided, but it needs to be interpreted with caution. There's been few advancements with respect to the management of inherited platelet disorders, and most attention needs to be paid to the prevention of bleeding as well as early pickup of complications. So these are the references that I used, and they were all really excellent references. Those complicated tables that summarize basically all 60 of the inherited platelet disorders is the third reference. And so I recommend that you read these references when you have time. Are there any questions?
Thank you, Farah. That was quite a lot of information, and thank you so much for summarizing a very complex set of disorders. And I must say that it's often, as Tennille had pointed out in her slides, you know, when we are consulted, often these patients would be, you're consulted by maybe a surgical discipline or the obstetricians for the first time, and then trying to maneuver your way down, trying to decide, you know, what you are dealing with. So it is very complex and not as straightforward as one may think. And, you know, one also has to realize that these tests are expensive, and you know, to start off with a good history and ensure that there are no drugs that are affecting it before going down the route of, you know, expensive testing. So just Farah, just a few questions. I know Rita has asked a few questions here, but I want to actually go to Tomic's question. He asked, would you be able to give a brief summary of the associated syndromic findings one should look for on clinical examination? I think that may not be an easy one. It just depends, you know, which ones are actually associated with bleeding. So Farah, would you be able to comment on one or two of them?
Yeah, so it's a difficult question because it's quite a long answer, and it's going to depend on what genetic defect there is exactly. So because each gene is going to have different roles in different organ systems, it's going to manifest differently. But basically, if you have a patient with a bleeding diathesis, or if you have a patient with a thrombocytopenia, you will examine them clinically and you will do some basic tests. So if you pick up that there's also skeletal abnormalities, if you find a history of recurrent infections, if you see that there's some cardiac abnormalities, if there's facial abnormalities, you know, all of those things are, and they're all occurring in one. So if you have like one patient who gets recurrent infections that has a facial abnormality that tends to bleed, that is pointing to there being something syndromic. I'm not sure how to summarize it any further. I don't know if anybody else has a better way to summarize it, but I don't think that it's a simple answer. There's no like one syndrome that's going to manifest in a certain way, and they may not have all of the features that is associated in the syndrome at the time that they present to you. So sorry, I don't know if I'm doing your question justice, but it's a difficult question to answer and put into a little box.
No, I agree with you, Farah. I don't think I would be able to answer that very easily. Rita asked the question, so if there are any of the people from lab, both in private and state, she asked, please, may I know if any center is offering electron microscopic evaluation of platelet morphology? Maybe if you could raise your hand in the, that would help. And then she also adds, she says, great talk, Farah. May I add medical alert bracelet to management? Thanks. So that is an important aspect once you've actually found a patient with a platelet disorder, to actually encourage them to get a medical alert bracelet. Then Jacques,
I agree, the medical alert bracelet definitely, but also patient education. So your patient needs to understand what problem they have. Like in one of the cases that Tennille presented, you know, it only came out after a lot of digging that she was diagnosed with a so-called platelet problem at the age of 6. Could have saved people a lot of time. You know, if she came out up front and she said, by the way, I have this problem where I have an alpha granule deficiency, so I'm going to be a bleeding risk. So I think definitely medical alert bracelet, yes, but also patient education so that they can tell whoever is treating them that they are that bleeding risk.
Yeah, I guess that is important, because then you go down the route of doing all the expensive tests again and wasting resources, I guess. And then was Jacques has a comment here. He says, just to comment on the bleeding time, it is still a useful test in certain instances, especially when one considers a vascular cause of bleeding, example, Ehlers-Danlos, sena purpura, etc. So yeah, that that might be useful then. However, I'm just wondering, most labs don't do it anymore. So
I don't think people do. The last time I checked, it was because they didn't have the lancets that were required to do the bleeding time. I think that's one of the reasons that it's fallen away. But I stand to be corrected if somebody else
But
does offer it.
Jacques says his lab still does it. He just put on a comment.
You
Yeah,
send
but I
our
know
samples to you.
they send our patients to Jacques to do it.
Yeah, it's something that, I mean, the little lancet is a problem,
Yeah.
and it's obviously quite dependent on the technique. But one of our colleagues in the lab here has got quite an interest in it, and we still do it in sort of workup for patients where we are considering, and we have these sort of unknown causes of bleeding. You don't find really anything else, and it could be useful in those settings. So we still do it from time to time.
Definitely.
And Rita says she does say AMPAT also offers this bleeding time. Rita, nobody offers electron microscopy of platelets, it seems, because I've got no
I wonder
no
if it's not available through universities, though.
Yeah, possibly. I mean, you have to find these people doing it. Jacques also. Jacques. We previously have been able.
We have been able to do electron microscopy. Yeah. I'm not sure where it was sent to. Yeah.
Okay, so we can investigate that, and so
I just had one more comment. Is that with regards to the question on the syndromic features and when to suggest inherited platelet disorders, our unit recently inherited a child that was previously treated in pediatrics, was known to the orthopedic department because she was suffering with osteogenesis imperfecta. And for years, she was labeled as having an inherited platelet disorder, and she's been through multiple runs of all the platelet tests, the PFA hundreds, the flow cytometry. She's had them multiple times. A lot of those times, unfortunately, it was done while she was on NSAIDs. So naturally, all of her aggregometry results and everything came back prolonged. When she came to us, we just looked at everything, went through her history, looked at her bone marrow that was done, and she had a thrombocytopenia, but her bone marrow showed a prominence of megakaryopoiesis. We treated her with steroids, and lo and behold, her platelets are responding. So she's actually an ITP. So it's just important for people to remember, don't go by the label that somebody else has given you because you look syndromic for something. You may well have something that's simpler and easier to treat. So always question the label, especially when you're inheriting somebody. Is this diagnosis correct? Am I interpreting things correct? Were things done correctly? And maybe we should have stopped the NSAIDs before we did the PFA 100, which in this case was actually done. The PFA 100 was repeated and it was normal. So I think that somebody that was labeled as having a bleeding diathesis from osteogenesis imperfecta actually has ITP. It's a huge difference in management and her outlook. So just remember not to always believe the labels.
That's a good point, Bara. And Jacques has a comment here. He says here, we have also previously been able to make a diagnosis of a myosin heavy chain type of congenital thrombocytopenia by sending DNA overseas for testing in a research lab. Oh, that's interesting. It would actually be nice.
Come and work with you.
Yeah, Jacques. We have a fun time there working with the platelet themes.
It was actually again one of my lab colleagues who that actually just I think there was a article on one of the international labs, her review, and we contacted the contact of the article, and they were willing to test the DNA pro bono, and so it's sometimes worthwhile to contact, if one has an interesting diagnosis that you're considering, to contact the authors of these papers, and and one is sometimes able to make really nice diagnoses if the testing is not available with us. So yeah, it wasn't. That was basically one of the lab people finding somebody who's willing to do the testing for us.
No, it's interesting. We deal a lot with hemophilia and von Willebrand's, and so those bleeding disorders we are, familiar with. But it would be nice if we could all pool our data of all the patients we have in our clinics, just to see what are the odd things that we are dealing with. I mean, I know in our clinic alone, we just have a few odd patients with different disorders, but we don't have a huge number of patients with platelet disorders. And obviously, it would be nice to have a good, reference for what is happening in the country, because obviously I know this young girl that Farah was talking about, that everyone labeled as a bleeding disorder, was actually a child with osteogenesis. But we've got a family of platelet disordered, a family of sisters that's in our care, and then a few that we've had by and by, but really not a huge experience with these patients. I think the problem comes when these patients have to undergo some sort of surgical procedure that we need to be able to manage them safely during those procedures. So if we do not have the experience, it may not always be that simple. So there's a few other comments here. So Jasmine says that she enjoyed your talk on Farah and Tennille, and she says, in addition to the bleeding time, do other centers perform the HES test? So less invasive suggestive collagen vascular disease. Thank you. So that was Jasmine. Does anyone have a response to Jasmine's query? Please, if you'd raise your hand.
I've personally heard of anyone doing the HES test. The HES test is, if I'm not mistaken, the tourniquet test, where you apply a tourniquet for about 5 minutes. And the expected result, if somebody has an issue with capillary fragility, is that there'll be a shower of petechia below the tourniquet. I'm not sure about less invasive, and I don't know if anybody actually does it. But it used to be a test that was done in scurvy, if I'm remembering correctly, because of the collagen that was not well functioning because of the vitamin C deficiency. But I don't know. I stand to be corrected if anybody still does the HES test.
Well, it's the first time I'm hearing about it, guys. So I've been educated. So there's Anne Louise. She says there are platelet disorders listed on Red Cap Bleeding Disorder Registry. Okay, thank you for that information. Maybe we should actually enroll our patients onto that registry. Thank you for that, Anne Louise. Let me just go through the chat again and see that I've not missed anybody's questions or comments. So I think we've been through everything. And is there anybody else that wishes to be so Rapodile says thank you, Farah and Tennille. So if there aren't any more questions or anybody that wants to contribute, perhaps anyone with more experience than us, if you want to add anything to this, please can you raise your hand and comment?
Charlene, I can just maybe make a quick comment that maybe it was, I joined late, so maybe it was touched on earlier, but I think we mentioned that sometimes it's an ITP, but it could go the other way around, that somebody is treated as a resistant ITP and you actually miss a congenital thrombocytopenia. In our case, with the myosin heavy chain, actually presented that way, referred as a resistant ITP, and actually underwent a splenectomy prior to referring to us. And then when we saw her, had clearly dysmorphic features and very abnormal platelet morphology. So she actually underwent a splenectomy for nothing. So yeah, that one should actually, I think, also just always consider it in any patient with resistant ITP, or that you're treating as a resistant ITP.
I think that's a good point, Jacques. I remember when I first started as a registrar in hematology all these years ago, I have only ever experienced one AMAT megakaryocytic thrombocytopenia patient. It was a young girl. And so these things are rare. And yeah, so just brings back some memories. So yeah, some flight of ideas. But thank you, everybody. I don't see any more questions or comments on the group. And so I'd like to take the opportunity to thank Farah and Tennille again for their wonderful presentations, and for everybody that contributed. I think this was a very informative session, and thank you all for staying as long as you did. And please complete the survey at the end, and we will see you next week. Have a good evening.